Welcome again to Clinic to Community Culturally Grounded Interventions in HIV and STI Care. This session is part of the Clinic to Community series, which explores innovative HIV and STI care initiatives designed for urban Indian communities with a focus on cultural competency. So in this session, our wonderful speaker will discuss the impact of syndemics on urban American Indian and Alaska Native health needs, the role of historical and intergenerational trauma, and lessons from HIV, HCV, and STI prevention studies. Additionally, we will consider culturally grounded interventions that address the unique needs of urban AIA and communities, and continuing nursing education credits are available today. So thank you again for joining us. So my name is Divya Nanduri. I'm a technical assistance manager here at NCUIH, and joining me from the NCUIH team are Kayla Emmerich, public health associate, Margot Bailowitz, public health project assistant, and Carmen Toft, associate director of communications and events. We kindly ask that you place your name, organization, tribal affiliation, and title into the chat box. And if you have any questions or encounter any technical difficulties, please reach out to any of the mentioned staff members for assistance. All right. So before we proceed, it's important to bring your attention to the following disclaimer that this event is made possible by the Minority HIV/AIDS Fund through the Indian Health Service. Now I'll review disclosures related to this continuing education activity. This activity is jointly provided by the National Council of Urban Indian Health and Cardia Services. Cardia Services is approved as a provider of nursing continuing professional development by the Montana Nurses Association, accredited provider with a distinction by the American Nurses Credentialing Centers Commission on Accreditation. Receive credit for this activity, participants must meet the following requirements: attend the entire CE activity, complete the online evaluation, and submit an online CE request. Upon successful completion of the steps, participants will be awarded 1 contact hour. Certificates will be sent via email. For any inquiries regarding this CE activity, please contact Steffi Droves at sdroves@cardiaservices.org. Your feedback is valuable to us, and even if you are not seeking CEU credits, we encourage you to complete the online evaluation to help us improve future events and better serve the community. Thank you for your attention. We will now proceed to the main content of the session. So as shown on the agenda, we'll begin with the session overview and some housekeeping, followed by an introduction to our wonderful presenter and the presentation. And we will end with a Q&A and adjourn promptly at 3 p.m. Eastern Standard Time. So for those of you that are unfamiliar with NCUIH, here's a brief introduction. The National Council of Urban Indian Health, also known as NCUIH, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V Urban Indian Organizations, or UIOs, under the Indian Health Service and the Indian Healthcare Improvement Act, or IKEA. NCUIH strives to improve the health of over 70% of the AIAM population that lives in urban areas supported by quality, accessible healthcare centers. As we proceed, please note the following. The session is being recorded. All mics are muted unless otherwise directed, and you are able to type your questions into the chat box, and one of our staff members will address them. A QA session, again, will follow at the end, and please complete the evaluation link provided in the chat to receive CEU credits. So to ask a question, select chat at the bottom of your Zoom screen, type your question or comment into the chat box that appears on the right side of your screen, and your question will pop up. All right, so before we continue with our presentation, we are going to be displaying a brief knowledge check, so please select your answers for the following questions in the pop-up box. All right, looks like we can go ahead and end our poll. All right, and let's share results. Okay. So understanding of the interaction between multiple health conditions. Okay, some have some understanding and some understand it well. The second question, some are neutral, some agree, and some strongly agree. All right. For the third question, everyone has great, yeah, effective, I believe culturally tailored approaches are in enhancing community health outcomes. Highly effective, wonderful, great. So it looks like we have a range of knowledge here. Thank you so much for participating. Right, so thank you so much for your responses to this poll. We will now turn the floor over to our wonderful speakers. So please join me in giving a warm welcome by placing a heart emoji in the chat box or using a heart reaction for Kerry Hawk Lessard.
Well, thank you, everyone. Again, I am Kerry Hawk Lessard. I am the Executive Director of Native American LifeLines. I am an applied medical anthropologist. And if you don't know what that is, really briefly, we study the place where culture and health intersect. And so what I'll be talking about today is the way that the culture that we have as Native people can impact not only how we experience risk of HIV, but also the ways that we prefer to, or the most successful ways that we have to prevent and treat HIV. So we can go to the next slide. And that's, yeah, so this is a picture. I like showing this. So this was a mural that existed for a really long time in Baltimore City, not far away from our office. But you can move to the next slide. So the things that we'll talk about today, anthropologist Meryl Singer is one of the pioneering scholars to discuss syndemics, at least in terms of HIV, substance use, and through medical anthropology. But we'll talk about that specifically as it applies to urban Native health, including HIV prevention. We'll talk about historical and intergenerational trauma as a syndemic condition, because historically it wasn't always talked about in the literature that way. I'll talk about some lessons that we learned here when we participated in a CSAP, or Center for Substance Abuse Prevention study, focused on HIV, Hep C, and STI prevention needs in our community in Baltimore. And then consider culturally grounded interventions that really allow the Native community to identify what their needs are and allow us to respond to the needs that they articulate themselves. Next slide. So some quick information about Baltimore, where I am located. Baltimore has a smaller Native population, 0.2% of the population, but Baltimore has typically been overrepresented in intravenous drug use, opioid use, and violence. We tend to have a younger population when compared with non-Hispanic whites, and we have a very diverse population. Baltimore was at one point in time a place with a great deal of industry. We had Bethlehem Steel and Dundalk, a number of factories here. If you've heard about the Key Bridge collapse, many of our tribal members were actually serving in the industries that surrounded the port. And so that's a kind of a way to connect with place. Again, diverse tribal population. We have many folks coming up from the Lumbee tribe of North Carolina to work in Baltimore. We also had a lot of iron workers come from Haudenosaunee tribes. We've seen that as industry has dried up here, most of those folks have returned from Haudenosaunee communities to their home territories, but we still have a large Lumbee tribal population. In addition to that, we have a lot of world-class universities here, including Johns Hopkins University and the Center for Indigenous Health. So we have tribal people living in our area, teaching and working. Unfortunately, we do see significant opioid use behaviors in our community, along with high rates of poverty and homelessness. Concurrent with that, we see low employment, low educational attainment. So all of the social determinants of health markers, unfortunately, we are hitting those. And so that's really kind of where my story starts. I'm 55 years old. I remember being a very young person when the HIV crisis was very new. Back then, it was the GRID, the gay-related infectious disease. And there were 4 categories of people at that time that were considered at most high risk. So heroin users, homosexuals, Haitians, and hemophiliacs. So the 4 H's, and that a group of people, Haitians, was singled out as being carriers of disease was very disturbing. And so when I was in college, I was going to college in South Florida, again in the early 90s, where we don't have the HIV medicines that we have now. And at the same time, I feel like there's always political instability in Haiti, but there was a lot of political instability at the time with the deposition of the president, Aristide. And so we saw a lot of Haitian immigrants coming to South Florida. And this is where the medical anthropology comes in. I was working in that community, living in Little Haiti, and really came to understand that at that time, the idea of HIV as more of a spiritual condition and less of a medical biological condition was something that we really had to have a lot of discussions with. People were very integrated into their Vodun culture or botanique, or the botanical, the herbal healers. And so if people believed that HIV was caused by something that had a spiritual or supernatural origin, their first desire was to treat it with a spiritual or supernatural remedy. People could not get back to Haiti at that time. So it really required a discussion for us to understand what type of treatment will people accept that incorporates, their traditional values and beliefs, but also Western medicine. I had a pivotal moment working in the community where we visited a community member who was experiencing AIDS-related dementia. That is not something that we see a lot of now, fortunately, but this presentation mirrored what a cultural belief of what a zombie would look like. And in that moment, I realized how important culture was in dictating how we have conversations about health and healthcare. And so when I returned home to Baltimore in graduate school, I wanted to apply that lens to better understand why in our urban Native community in Baltimore did we see the kind of substance use, mental distress, violence, and risk of HIV, hepatitis C, and STIs that we were seeing, and really understanding to what extent could the resilience that was embedded in our culture be a preventative factor in that work. Next slide. Here's something that complicates that, and I'm sure folks working in Native health understand this pain point all too well. In Baltimore City, if I want to be tested for HIV, I can be white, Black, Asian, Latino, or other. There is no place for me or for people like me to identify that we are American Indians when we are testing for HIV. So the numbers are always going to be wildly inaccurate. At one point, many years ago, I attended a meeting at the state, and I asked the epidemiologist speaking at the time to better explain rates for HIV in the American Indian Alaska Native community. And what he told me was, your numbers are too small and they don't count. And so I was fortunate to have Dr. Patrick Chalk, who was the Ryan White Bureau Chief of the Baltimore City Health Department, there in the room with me, who stood up and said, the numbers are important and I'm going to make sure that you count them. And so what Dr. Chalk did was direct testing at Baltimore City testing vans at that time to begin not only collecting American Indian Alaska Native data, but also tribal affiliation. And so, we really see that sometimes we need to advocate, but we need to connect with the decision makers who have the power to ensure that our data is collected. So, looking at this graph that I've shown you here, you see non-Hispanic, Black, and Hispanic have high rates for 2022, but then another race is the third highest group. Wouldn't you be curious about who those people are and how to best direct prevention methods to them? So I would expect many people in urban environments have similar challenges, and it's really up to us to advocate for better data collection practices so that we not only get the resources that we need, but that we can direct prevention information where it needs to be. Next slide. So talking about syndemics, again, I mentioned Merrill Singer. He's from the University of Connecticut. And I've shared here his definition of syndemics, that it's the concentration of deleterious interactions of two or more diseases or other health conditions in a population, and really focusing on the social inequity, the unjust exercise of power embedded within that. I think pulling away from that, what we've seen in our community, again, that every risk factor that you have increases other risk factors. So if you live in a community where substance use is very present, that's a risk factor. Then poverty on top of that. Maybe you're engaging in sex work to support your family or your substance use. Maybe mental health is a part of your picture. And so all of these things add up, and they really increase the opportunity for there to be risk in communities, both for contracting infectious disease, but also not having the best outcomes in treating it or even making it into pathways to care. So for us here, really understanding in our community what is actually happening at a ground level that is posing such risk to our people, and how do we address that? Next slide. A big part of the picture for us and for many tribal communities, I would say all, is the issue of historical and intergenerational trauma. And that's something in my graduate work that I really looked at. I always privilege Indigenous scholars when I'm sharing information about this. Maria Yellowhorse Braveheart, of course, everyone knows, is a preeminent scholar in talking about historical trauma, but she really talks about how we carry from generation to generation, whether it is the trauma of boarding schools, the trauma of losing your place, and or relocation. Let's say you live in a place where your surroundings, the mountains maybe, are important to understanding who you are as a Native person, or that your spiritual practice is grounded there. And now you're moved to another place, or you're forced to move to another place. What does that do to you? If you're living in an environment where people don't acknowledge you as a Native person, how does that impact your sense of identity? So all of these things really can be factors that pose risk. And we'll talk a little bit more about how my community articulated and experienced historical and intergenerational trauma. And then Joe Gahn, currently at Harvard, I like that he focuses on the loss of language and culture in Native communities, and that these can be very disorienting factors. Oftentimes, in our languages, they explain, very important facts about, again, who we are as Native people, or aspects of our culture. And so when we're left without that, or we don't have the words to use, the words that maybe our ancestors, our grandparents used, that is another form of trauma. Next slide. Considering historical trauma, specifically around the issue of infectious disease, HIV, hepatitis C, STIs, I had the opportunity as a graduate student to participate in a Center for Substance Abuse Prevention project with Dr. Jeanette Johnson, who's Huron, and Dr. Shelley Viekelt. The name of that project was called Don't Forget About Us, which wasn't my favorite name, but that was the name that we had. The objectives for that then were really looking at how can we deliver prevention services to the Native community in Baltimore, again, with a focus on HIV, Hep C, STIs. How do we make sure that the work that we're doing is not just culturally grounded, but appropriate to the communities that we're serving? And for example, if I am serving in a community that is predominantly Diné, do I want to always use Lakota terminology when I'm doing that? No, I want to understand the community in which I'm working. And then we needed to use the SAMHSA strategic prevention framework. So, what are the needs of our community? How can we build capacity in the community to address those needs? What does our strategic plan look like? How could we identify what effective programs and policies there were and implement them into our community? And then stepping back and evaluating how well that worked in community. Next slide. So the things that we found through through focus groups. So I was brought in as a community member and as a graduate anthropology student to run focus groups with people in my community. Most of the people in the group were people that have known me since I was a young woman. And now I find myself in a position that I'm working with people who've either known me since I was very young or that I have known them since they were very young. And so being able to talk about something as sensitive as HIV, hepatitis, and STIs, that was something to factor in. How comfortable are people in my community going to be, and how willing are they going to be to have very real conversations about these issues, especially when it comes to talking about sexual behavior or drug use, things that people might experience a lot of stigma around. At the time that we did this study in our community, I would say Baltimore had a very conservative evangelical community. And so folks that I knew who might be two-spirit or questioning did not feel safe to talk about not just who they were as two-spirit people, but sexual behaviors that they might be engaging in, so that we could have real conversations about prevention. So I think when you can do study or work as a member of the community that you're working in, that can be really helpful and provide an advantage. At the time that I went into grad school, there was still some debate about whether Indigenous people should be studying in their own communities. And I'm glad to say that that's different, but I received a lot of support from Dr. Marilyn Bentz at the University of Washington, and Dr. Pamela Jumper Thurman, a citizen of the Cherokee Nation. At the time, she was in Colorado, but really driving home how important it is that as Indigenous people that we lead our own science, and that we lead our own research and what the solutions are, because we can make sure that we are as responsive and best responsive to the people that we're serving in ways that will really have impact. So talking with folks in our community, what they cited as risk factors, first of all, community disintegration. In Baltimore, most of the Native people lived in an area called Fells Point, but it was near the harbor. But as the years passed, gentrification occurred that pushed Native people out, or maybe drug use and violence came in that people with young children didn't feel safe living in the city, and so they moved to the county, whether that was for a better quality of life or educational experiences for their children. But folks in our community talk about seeing community disintegrate and also seeing the community fall victim to intergenerational substance use and intergenerational neglect. And I always think of Maria Yellowhorse Braveheart talking about the boarding school experience, for example, that if you are taken from a loving community and a loving family, and placed into a boarding school system, you are no longer being parented, and then you are receiving any type of like pseudo parental care by people maybe from a religious institution that is not your own, or a military institution that is not your own. You are not going to know how to parent in the ways that you would have otherwise been parented. And then you return to your community not knowing how to parent, that you have children that you perhaps don't parent in the way that you would like to, and that cycle replicates. And so looking at how do we change that? How do we improve things in our community? It's also the fact that stigma and shame were big themes identified in our community, that for this particular group of people, they felt that because they maybe were Afro-Indigenous, or they didn't look like what one person said, like the guy on the nickel, so not kind of the stereotypical image of what someone thinks a Native person would look like, that they felt a lot of shame about not living up to maybe what the idea of an ideal Native person would be. And Vine Deloria talks about that as well, that there's this iteration of this kind of super Indian, that because Native identity is often informed by non-Indigenous people, that Indigenous people find it's very hard to live up to that mythological image. And so people in our urban environment, disconnected from their traditional tribal cultures, felt a lot of shame, especially if they didn't speak their Indigenous language, or maybe, they didn't go to Sweat Lodge, or they didn't know about Sundance, things that they felt that they should know, that they didn't know, caused them a lot of feelings of shame. And then they talked about urban lifestyle and peer influences. And I think that was a nice way, a softened way to talk about just the very active drug culture that was happening in Baltimore at the time, and to some extent still occurs. If anybody has watched The Wire, I know that some of our legislators hate that program, but if you live in Baltimore, you know that there's a lot of realism in the presentation of that. And so understanding that members of our Native community are living in the same neighborhoods as relatives in the Black community, and experiencing the same levels of crushing poverty, gang influence, just, not access to green space, and being afraid to send their kids outside because, there's gun violence, that those things also played a role in people's experience of risk. And then socioeconomic disadvantage, people's experience of poverty and feeling like they could never do better for themselves, that they were trapped in the system and didn't see any way out of that. These people in our community would talk about how self-medicating with drugs and alcohol would be their relief from these risk factor, or the relief from these social pressures, but then that would expose them to greater risk. Next slide. So in our community, 3 themes really came out about why people felt that they could not achieve and sustain wellness. And so we looked at cultural disconnection, invisibility, and lateral violence as a part of social determinants of health. Currently, LifeLines is trying to work on a project that is going to, if you're familiar with other, like the Whitbeck scale of historical trauma that looks at culture losses, language, land, really understanding that historical trauma is a social determinant of health, in as much as poverty, structural violence, all of these other kind of limit situations, and really understanding how we address our health needs when we consider historical trauma as a social determinant of health. And I pulled out some things that our community members talked about. One, people really clearly articulated that disconnection from their tribal culture is a huge problem. I think if I'd had stronger culture, we would have lived differently. We would be better if we had those values. We would be stronger as a community. There was an individual that shared a story with us that when she would get up in the morning, her father would force her to get high with him. And then she would go to school and she wasn't able to perform well. And then she'd get bad grades and she would come home and get in trouble for bad grades. And she, said, like, I felt like I couldn't win either way. I'd either get my ass beat if I wasn't getting high with my dad, and then I'd get my ass beat if I wasn't doing well in school. And so I just gave up. And she talked about that as being a contributing factor into her substance use journey. Also, the issue of lateral violence was a real problem, as well as invisibility. We have a large number of Afro-Indigenous people in our community. And so to have other people outside of the Native community kind of weigh their indigeneity was very painful for them. They felt very firm in their identity as Indigenous people, but when they had that questioned by other people from outside of the Native community, that was very painful for them. We saw this here in Baltimore during the time of the uprising after the murder of Freddie Gray, that the Native community here took some criticism about, hey, why aren't you hitting the streets with everyone else? And folks from the community would say, like, you know, when you are burning down the CVS, let's say, like, that's our stuff. Like, you're coming in from other places into our community and you're leaving destruction, and we already are living in poverty. We can't possibly rebuild what was lost. So, you know, feeling invisible in a city that they call their home was also a trauma for people in our community. And then the idea, there was one member of our community um, that my nephew came to visit from Pine Ridge, and she's Lumbee, and she referred to him as a real Indian. And that really broke my heart, that she didn't see herself as a Native person, or understood, because of the laterally violent ways that we sometimes speak to each other, that she wasn't seen in that way. And so she felt very culturally less than, and articulated that as one of the reasons that contributed to her substance use. So really hearing from the community what they felt was the source of their problem, it all came back down to trauma. Next slide. So if we hear from our community members that trauma is causing them to engage in health demoting behavioral practices like IV drug use, like unsafe sexual behaviors, if they are in situations where there is violence, or if they're simply just not taking care of themselves because they don't believe that they're worth taking care of, those health demoting behaviors expose them to risk. And there was the big influence, the big syndemic situation where the co-occurring disorders of HIV, hepatitis C, and STIs were very prevalent. Because again, if you are not able to give consent in your sexual practice, and maybe you're not using a condom, or you're not giving the opportunity to use a condom, not only are you at risk of STIs, of pregnancy, but you're also at risk of hepatitis C and HIV. And so having conversations about what we can do to protect ourselves became very important in our community, because people articulated that the kind of cascade, you're operating from a place of trauma where you're in crisis mode all the time. You feel the limit situations of your circumstances really bearing down on you, that you can't even envision how you can do better, that created a vicious cycle where poor health outcomes were more the norm. And so if people are identifying lack of connection to culture as the thing that is making them unwell, then we chose to invert the paradigm where we re we bring cultural practices back to the healing work that we are trying to do. As an anthropologist, I hate hearing people talk about cultural competency, because I kind of think that's BS. I think you can be competent, but it really should look like cultural humility, that you understand that you can't possibly know, I can't know everything about every practice of every tribe. I need the people that I'm living with to tell me what they accept and what is important to them. And in HIV prevention literature, we would often see that as, you know, just a brochure that had all of the same written information in it, but there would be kente cloth on it for the Black community, or there would be a serape for the Latinx community, or a feather for the Indigenous community. Nothing in those materials spoke directly to any of those communities particularly. So really understanding that we needed to have a fundamental change in the way that we were talking about information and disseminating it to our community. I had the opportunity to participate in some discussions when my spouse was working at Howard University on the Be Safe program, but really having a curriculum that came from tribal communities to talk about prevention methods and how to, you know, negotiate conversations around sex and sexuality when, for example, those are things that you're not comfortable talking about with your elders, or maybe there are taboos in your community about talking about sexuality or different gender identities. Really understanding from the community what is acceptable and then moving forward in that way to a place of healing. Next slide. Again, I want to mention her name again because she's one of the most important people in my life, but Dr. Pamela Jumper Thurman, really led a lot of community-based research and HIV prevention in Indian country. Even the CDC had to acknowledge that to be effective, HIV prevention programs needed to be adapted to our individual cultures and our beliefs, and that was really important to having sustained and meaningful treatment. So for us to create prevention models that incorporated that and promoted wellness in our community really was going to be how we could make a dent in prevention and how we could sort of untether ourselves from the practices that are rooted in trauma. Next slide. So the ways that we chose to do that through cultural grounding and cultural humility was first to identify impacts of settler colonialism. So to the person that doesn't know their language, letting them know it's not your fault that you don't know these things. So don't continue to beat yourself up. There is still time to learn. Rejecting lateral violence, anti-Blackness, and homophobia, transphobia in our communities. Really, as an organization, being out front that we hold place for our Two-Spirit relatives and for our Afro-Indigenous relatives so that it is understood that it is not our way, not our cultural practice to be hateful to people in any way. And then allowing, as I said, cultural reconnection without judgment. That was, allowing space for people to learn things and to interact with people from their tribes at home as a way to heal. Next slide. And really embodying and embracing the idea that culture is healing and culture is prevention. Next slide. So an example of how we do this, National Native HIV/AIDS Awareness Day is the first day of spring every year. For our community, it might be difficult to say, hey, come on out, we're going to get you tested for HIV and teach you prevention methods. Very few people would actually come if we said that. And so what we've chosen to do to observe National Native HIV/AIDS Awareness Day and really get prevention messaging out is to host a round dance. So we invite the community to come for a social and cultural activity. Here we have, our drummers from all over. And then in that environment where they're participating in a culturally meaningful social event, provide opportunities for HIV testing, provide opportunities for education, provide a meal for people so that the prevention is embedded in our culture and what we would already do to begin with. Other ways that we've done prevention work around helping people build a drum, understanding that the same way that we care for a drum is with medicine, the same way we care for our bodies with medicine. People in urban environments don't often have the opportunity to make a drum or participate in round dances, or other cultural activities like a nipi, which is also something that we do, sweat lodge. So really providing those as the foundation, privileging Indigenous knowledge and Indigenous ways of being, and then providing prevention messaging in with that, so that you're giving something that nourishes people's soul, but then also gives them solid prevention information that allows them to be healthy. Next slide. Our takeaways, basically reflections from community, and this t-shirt I want to talk about really quickly. The first one, normalize talking about sex and sexuality. What we heard from people in our community is that a lot of health promotion, disease prevention messaging coming out of the communities is really family friendly, and they wanted something edgier. So we asked people to tell us the slang on their res or in their community for, having sex. And so we had buttons and t-shirts with all these different sayings, and people really loved that, and it generated conversation. I was proud to see the tribal chair of Sault Ste. Marie wearing one of our pins around at meetings with legislators. So that was a high point in my life. knowing who our audience is, so knowing who to talk with, but also always being inclusive. Again, really letting our Two-Spirit relatives know that we hold place for them, letting our Afro-Indigenous relatives know that we hold place for them. And then we've had success in embedding our prevention activities within cultural activities. So again, things people want to do, things that affirm their identity and build their resilience, but also disseminate the information that you want disseminated for community health and wellness. And then making trusted connections. We had, and I'll change the name slightly, but one of our community members presented to Hopkins for care. And I'll use the name of my friend Leanne Bruised-Head. They presented to the front, "What's your name?" Leanne Bruised-Head. The person at Hopkins said, "I didn't ask what was wrong with you. I asked what your name was." Do you think that person ever went back to Hopkins to get care? They didn't. And it kind of left us feeling foolish to refer them to that place. So making sure that we are building trusting relationships in our community where we know people that we can say, when you go to this appointment for your HIV test, you're going to see Mike. Mike's going to take you this place, and Mike's going to call me if you have any problems. So if you have the luxury of making connections in urban areas with non-Native partners and really vetting them, it is so important. It's just so important. Next slide. Final thoughts. Our healers have always been part of our communities. So making sure that we are providing opportunities for, our traditional healers to come in, our drummers, our singers, people who work with plant medicines, but also really trying to hire from our community. And if we don't have enough Native people in our community to fill the roles that we need in public health, helping people get that education so that, we are really replicating the patterns that have always existed, where again, our healers have been part of our communities. Letting community members lead. We very much believe in a bottom-up approach. So let folks tell us what they need and then try to deliver it that way. I use the Hopkins example, vet your partners. Remember the value of your social capital, that if you from Native American LifeLines send someone to a horrible place, not only are they going to have a bad experience, but they're going to tell everybody in the community, your urban Indian program sent them to a horrible place, and it damages your trust. And then prioritizing local Native culture. So again, letting the cultural experts in your community let you know kind of visually and aesthetically how they would like to see information presented. And then be a safe organization and a safe person. I have tried my best to make people comfortable talking with me about their sexual behavior, about their sexuality, about violence in the home, knowing that I'm not going to judge them, but I'm going to help them get the care that they need. And they're always going to be treated with authentic affection and care from me as a relative. And that, I think sometimes we undervalue the importance of that. And I think that authentic care and compassion is the most important thing that we can do. Next slide. I think that's it. So yeah, we had this wonderful doormat in our facility in Baltimore, and our Diné relatives always laughed about it. So that has to traditionally be the ending to every presentation that I do. So thank you very much for listening to me talk about our program. I hope some of that was helpful to you, or reaffirm stuff that you're already doing in your program, or maybe gives you ideas for ways that you can work in your community, and let them really lead those interactions. So I will shut up now.
I wish you could keep talking forever, Kerry. This was an awesome presentation and super, super informative. Like I was completely mesmerized and I learned a lot. So I think we should definitely give a round of applause to Kerry for that amazing presentation, all that. So yeah, like definitely in the chat, in the reactions, all of that. It was an amazing presentation. Thank you so much.